it still works, so we'll move to step 4 and so on. If the patient is improving, so we go down the step down, and so on. This is symptoms versus treatment. Symptoms versus treatment. Let us start from a patient newly discovered or newly diagnosed patients, or a patient come to your clinic having a symptom, for example, of very variable symptoms of shortness of breath every 3 months, or once every 2 or 3 months. Yeah, it's very intermittent, coming from time to time, but not a typical picture of a severe asthma. So in this patient, should we start him on all the course of the asthma, what we mentioned, the steroids, the beta blocker, and so, the beta 2 agonist? I think no. We should now, like this, set him on a step suitable for his symptoms. So here in this case, it's suitable to step 1. Step 1 does not mean it's mild intermittent asthma. Any patient having mild intermittent symptoms, we'll start him on the inhaled beta 2 agonist as needed. 2 puffs as needed to be taken. Of course, this is in a specific time, a specific number, not in, we'll see this now. So, as PRN dose, if the patient is start to have this beta 2 agonist to be started and taken frequently, for example, he is consuming 1 or 2 canister per month, or he is consuming large amounts, for example, 10, 12 puffs per day, and still having the symptoms. So we have to think that this patient is uncontrolled or having other problems. Now, to assign this patient to other step, if the patient having these for example, symptomatic, he's more than 3 times per week, or he's using inhaled beta 2 agonist frequent time, 3 times per week, or waking up at night, weekly, for example, or every other day, having frequent exacerbations, or having impaired lung function by the peak flow meter or spirometry, I think this time we have to assign to another step. So we have to assign in step 2. Step 2 means that we should set him on a regular preventer therapy. What is the preventer therapy, you know?
Steroid.
The first line preventer therapy is?
Steroid.
Inhaled corticosteroids. This is the first line. The dose, you have the range from 200 up to 800 microgram per day. We have different types of corticosteroids. We have the Picotide inhaler. We have the Pulmicort inhaler. We have the Flixotide or fluticasone inhaler. And you set the patient to the dose appropriate to the severity. For example, this is in between 400 is acceptable if mild or moderate severity. If very severe, we can start up to 800 microgram. Okay? Give the steroid twice daily, in 2 puffs twice daily, and then follow this patient and see the response. Usually, he will have a good response if he will respond to this steroid dose. And then you can taper or not taper to make it, for example, the lowest dose at which the effective control is maintained, and we can even make it at once daily, for example, with the whole dose at once daily, if he is now going well with this dose. If these symptoms are seasonal, for example, he is pollen allergic asthmatic, we can set or start this medication or treatment prophylactically before the pollen season start. Yesterday we showed you a chart for the pollen, for the grass, for the molds. What is the season for these pollens? You remember the June, July, summer month? So there are certain seasons that the asthma will start the symptoms. So we can start the preventer therapy period before the season, 3 or 4 months. And it should be continued even after the season. Now, still the patient having symptoms, still symptomatic, still having exacerbations, still having sleep disturbance, still having restriction of activity.